everyone, and thank you for joining today's educational webinar with Cancer Support Community Los Angeles. I'm Kathy Riley, the Community Partnerships Director at CSCLA, and I'm really honored to welcome you to this week's webinar titled Sexual Health in Men After Cancer. And before we begin, if this is your first time joining us, Cancer Support Community Los Angeles is a premier nonprofit organization that provides vital social and emotional support to families facing cancer. And that includes patients and caregivers and their loved ones, all at no cost. And our programs include support groups, healthy lifestyle activities, social activities, and educational programs like this one. And if you would like to learn more about our services or watch past webinars, you can visit our website at cancersupportla.org. And before I introduce our speaker for today, note that your video and microphone are automatically disabled for this webinar, but we welcome questions for our speaker. And so enter those into that Q&A feature found at the bottom of your Zoom window. Questions will be answered at the end of the presentation. We may not be able to get to all of your questions today, but we'll get to as many as possible. The chat is also open for you, and use the chat feature to share comments and resources with other participants or to ask questions of CSCLA. We ask you to limit chat comments to information relevant to this topic. And I'll go ahead and introduce our speaker. Dr. Juan Andino is a board-certified, fellowship-trained urologic surgeon with a focus on cancer survivorship in the areas of erectile dysfunction, prosthetic surgery, and male fertility. He completed advanced fellowship training in male reproductive medicine and surgery at UCLA, following extensive experience in prosthetic and microsurgery at the University of Michigan. And it gives me the greatest pleasure to welcome today's speaker, Dr. Juan Andino. Dr. Andino, welcome.
Thank you so much, Kathy. Lovely introduction, and thank you all for being here today during your lunchtime. Let me get our slides up. All right, everyone. Good afternoon. Thank you for joining us during this lunchtime. And as Kathy mentioned, please feel free to utilize the Q&A feature as we work our way through the presentation. So I have the privilege to speak on this topic, sexual health after cancer care, an area near and dear to my heart. As you heard, I work here at UCLA Health in the men's clinic, and I also spend Mondays down at Martin Luther King Jr. Community Healthcare, talking to men and patients about these topics. So just a big picture overview. We're going to talk a little bit about what cancer survivorship is and means, and then into the nitty-gritty areas where I see a lot of men in our clinic. And that ranges particularly the span of erectile function, ability to have penetrative sexual ability, male fertility or infertility, and how that might be impacted by cancer treatments. And lastly, a little bit more focused or niche area, but particularly for our patients who are having prostate cancer surgeries, there can be stress incontinence or leakage of urine with activity. We're going to start very broad and kind of narrow our way down. So first of all, what is cancer survivorship? I'm sure many of you have heard this term thrown around, and I love this figure from a urology kind of overview paper that I found, and it really ties in all these different aspects of care that take place after someone has had a diagnosis and a treatment for cancer. And for any man, this may involve a variety of different treatments, sometimes many of them for the same person. So it can include surgery, radiation, chemo, now in the modern world, immunotherapy, and prostate cancer, hormone therapy. And now you're in the space of surveillance. Perhaps the cancer is deemed to be treated or no evidence of disease, but there's still either imaging or laboratory tests. And many people, by the time they make it to our clinic, kind of share this concept of, for a long time, the only thing that takes up space in your mind is the idea of survival. Am I going to be here? Am I going to survive this? How am I going to share this with my family? And at a certain point after undergoing these therapies and when successful, there's a little bit of a frame shift that allows patients to engage a little bit more directly and proactively in their own health to now say, well, I'm here. We've gone through the treatments. Now, what can we do to optimize quality of life, not just quantity of life, but quality of life. And this is a key portion, in my opinion, of what we call cancer survivorship. And so this really is this focus on restoration of quality of life, feeling that you can do the things that you want to be doing. And I think a critical component, and the reason I highlighted it here on my slide, is that it really has to be on your schedule. There's no one exact timeline. And for some people, they will very honestly say, look, it took me 2, 3 years to come in and talk about this because maybe erectile function wasn't the number one priority for that time. And that's okay. It really is meant to be an elective thing that is done based on your goals, your preferences, your values. And within this realm, though, we will focus today, as I mentioned, on erectile function and dysfunction, one of the most treatable things that I see in our practice here. Ejaculatory and orgasmic dysfunction can be a little bit more challenging, but I'll give a little slide overview on this area. Fertility and fertility in particular should be addressed before treatment, and I'll actually share a little bit of information that's unique to the state of California, where there's some programs for trying to preserve fertility prior to treatments that are known to impact this. And again, leakage of urine with activity, particularly after prostate cancer care. And pardon me, I have a little cold, so if I pause to take a little sip of coffee or water, just a necessity of having a toddler in the home. So first of all, what can impact things after cancer treatment? Well, surgery. Any surgery that is in the pelvis or in the lower back or near the rectum has a risk of impacting the nerves that travel through this area. That's what this figure is demonstrating, what's called the pelvic plexus and ultimately the cavernous nerves that travel right next to this organ here, the prostate. So we see this most commonly in men who have treatments for prostate cancer, radical prostatectomy, or even some focal therapies if the tumor is very close to the nerves. Radical cystectomy or patients who have bladder cancer and have to have their bladder and their prostate removed as part of that will also have an impact in this realm. And also, next on that list is patients who undergo any sort of rectal cancer surgery, low anterior resection, anything that, again, is kind of down by that prostate and that nerve area. There can be others, but these are probably the three that we most commonly see. And the reason being is that any sort of surgery, dissection, movement in that area will affect the nerves. In many cases, surgeons are trying to preserve them or protect them, but just the nature of the cancer surgery, where's the tumor, how much swelling is involved, will lead to at least some temporary impact on the nerve function and how much those nerves are able to recover over time. Similarly, if you go higher up towards the back, towards the spine, an injury of the back or an injury of the nerve roots here closer to the spinal canal is also going to affect the ability for that signal to make its way down from the brain through the pelvis to the penis to generate and maintain an erection. Interestingly, with surgery, you tend to see a more immediate effect. And again, depending on how much the surgeon was able to preserve those nerves, you may and hopefully should see some improvement over time. Radiation is actually quite similar. So still the most common areas where we see some impact are going to be, again, pelvic tumors, pelvic cancers, prostate, bladder, rectal. Any malignancy or lymph nodes in that pelvic area might be targeted with radiation. Very similar mechanism, but the timeline's a little bit different. With radiation, you tend to see a delayed effect. The patient may not have a very immediate or noticeable change in the erectile function, but 1, 3, 5 years later, there's going to be continuous, slow, progressive changes that might worsen to where the erectile activity and their erectile function becomes impacted. And we can't forget about systemic therapies or whole body therapies. This falls into the category of chemotherapy, now in the more modern space, immune therapies, and we'll talk a little bit about hormone therapy. Depending on what you're receiving as a patient or a family member is receiving, these types of therapies can put the body under some stress. They may affect the ability of the testicles to produce testosterone, or certainly at normal levels. These side effects that are directly related to the medications themselves, fatigue, nausea, may just make one feel crummy and not be interested. Number one goal at that point, if you're really fatigued, really nauseous, is not going to be interest in sexual activity or wanting to be intimate. And that can be normal in the short term, while going through these processes. But also, depending on the type of chemo or therapy, there can be an impact on blood vessels and nerves. And so that may manifest itself down the road as affecting the erectile function as well. Unique to prostate cancer care, There may be patients who need or benefit from something called androgen deprivation therapy. And these are, again, medications that affect the whole body, systemic, but they are meant to purposefully lower the testosterone levels as part of the prostate cancer treatments. And so those will be directly associated with low energy, hot flashes, libido totally falls off to the wayside, and worsening of the ED, at least during treatment, but sometimes even after completion of that androgen therapy as well. Ask your oncologist, ask your hematologist, feel empowered. You're the patient, and there's a lot of questions when you're receiving treatment for your cancer. But if this is an important part of your life, quality of life, your intimacy with your partner, it's okay to kind of pause during a visit and say, hey, can you tell me a little bit about the side effects in terms of sexual function, of whether it's chemo, radiation, surgery? It helps to have those conversations ahead of time. And for many folks that we see here at UCLA, some patients will actually seek out consults even before they start treatment to kind of optimize their sexual function as much as possible before, during, and after their therapies. As I mentioned, for this first section, we're really focusing in on the area where we have the most evidence-based and treatment recommended guidelines. And so erectile dysfunction, to put everybody on the same page, is the inability to attain or maintain penile erection sufficient for satisfactory sexual performance. And I think that satisfactory is a key word there because it's what matters to the patient. If at this point in time or in the future, that's not the number one, two, or three priority, it's okay. Doesn't mean that you have to go chasing down therapies or treatments, but if that's an important part of life, it's very important to know that we have multiple different treatment options that can help in this space, regardless of what you're going through in your cancer journey. And it is incredibly common. This is something that guys do not talk about. We wish as sexual health specialists that there was a little bit more of a shout from the rooftops approach, but these are numbers uh, without any involvement or engagement in the in the cancer survivorship world. So these are just population level numbers. And you can see that starting about age 40, about 40% of guys have erectile dysfunction. And with a little bit of rounding, you see that per decade, that percentage increases by about 10%. So across the entire United States right now, it's estimated that about 66 million men are already living with or suffering from erectile dysfunction. And as we get older as men, there's a little bit of a biological or aging component that's natural that it tends to increase the likelihood of having ED and also the severity of the erectile dysfunction. Importantly, when folks have gone through either surgery in the pelvis, radiation in the pelvis, or chemotherapy, immunotherapy, etc., the likelihood of having ED may go up further, and the severity, what meds or what treatments the body's able to respond to, may be higher as well. So instead of a mild ED, it may be a more moderate or severe ED. And it's important to know that first line therapies, you don't need to see a specialist to get access to these. Many primary care doctors, even oncologists, radiation doctors, will be able to prescribe these first line therapies if this is an important part of your quality of life. These includes things like sildenafil, the blue pill here, or tadalafil, which is Cialis. But look at these numbers in terms of efficacy. Across the board, across all patients, about 7 out of 10 men tend to respond to these oral agents. So they're really good options in addition to thinking about things like weight loss, cardiovascular exercise, not smoking, etc. But now, if you include patients who have either diabetes or who will fall into this cancer survivorship space, they've had prior prostate or pelvic cancer treatments, the efficacy or success rates drop down significantly from 70% down to 40 to 50%. So it's a little bit more of a coin flip as to whether your body is going to be able to respond. And education around using these therapies sometimes can get skipped by or not dwelled in enough detail when patients are receiving these medications. Of course, you're dealing with the word cancer and treatments and surveillance and labs and imaging. Well, it's very helpful to understand that medications like sildenafil, Viagra, or tadalafil, Cialis, do require the nerve function to be preserved or maintained to some degree. And they require stimulation. You can't just take the medication and then automatically, boom, an hour later, an erection has popped up. With sildenafil in particular, if you eat a high fatty meal, a lot of butter, a lot of grease, it will delay or diminish absorption. So sometimes it's helpful to take on an empty stomach or with a light meal. Daily Cialis we use quite frequently, and I'll show you some data as to why, but it can preserve this aspect of spontaneity. Some men appropriately get frustrated at the idea that, well, I can only perform in the way that I want to if I'm taking a pill about an hour or so prior to sexual activity. A daily use of tadalafil can actually help avoid that, so you don't have to plan so closely. And it's quite common to have to go up on the dose. Again, particularly folks who have gone through treatments, surgery, radiation, chemo, it may be that the lower dose of these therapies are not efficacious enough and that we have to go up in the dose as you're having these conversations. That's completely normal. And it's not that your body gets used to or resistant to the medication. That's a very common question we receive in our clinics. But it's actually that once ED rears its ugly head, unfortunately, it is a chronic and progressive problem, meaning it will always get worse over time. Unfortunately, nobody has found a cure yet. A lot of people are working on that. But what it will tend to require is changing doses, increasing doses, and then changing formulation type of treatment, which we'll talk about that in a moment. The other aspect that can be very frustrating for patients in particular is the insurance side. Sometimes the as needed Viagra will be covered, but something like a daily Cialis will not. And this is where it can be helpful to use tricks like these. And you can even, mention that to your doctor before you see a specialist. If they prescribe a higher dose and you cut a pill in half, you're going to get double the pills. That's helpful. The other thing is these programs like GoodRx coupons or the Mark Cuban Cost Plus Drug Pharmacy. Folks can get a much better price at a local pharmacy with a GoodRx coupon, or they can get these delivered in the mail, even when insurance doesn't cover it, for very affordable prices. And it's important to know anytime we're talking about medications, what are possible side effects. The good thing is that they rarely are dangerous, but it's good to be aware of these. Sildenafil, Viagra, more likely to get headaches. With both of these, you can get flushing or nasal congestion, just like I sound like right now. Daily use of these medications like Cialis or Tadalafil more likely to cause a little bit of heartburn or muscle aches, aches in the lower back or the lower legs. Thankfully, these are not, again, dangerous or not an allergy, but just something to be aware of and discuss with a doctor if they do occur. And there can be visual changes. And sometimes, particularly with sildenafil, you can get a blue or greenish tint to the vision. Not dangerous, not concerning. If you get a painful or pressure sensation in the eye, we worry about that a little bit more, and we're less likely to continue down the route of these oral therapies. Importantly, I don't think it updated in my slide, but I will say it out loud. The one area where we can't use these medications are patients who are taking nitroglycerin or nitrate-based medications. And that's where, just like in the commercials, if you're taking those two classes of medications, there can be an unsafe drop in blood pressure. And so that is one area where, from the get-go, a patient will be told, no, sorry, you're medically safely just not a candidate for these. And here's some data directly out of UCLA, which highlights how these medications can be used in the cancer survivorship world and why we prefer oftentimes our bias is towards using a daily tadalafil. Well, in 2019, actually 2020, the study was in 2019, our group published data looking at what's called penile rehabilitation, patients that were known to be undergoing either prostate cancer surgery or radiation, and how engaging in some care before and especially after their treatments helped restore the time to getting kind of to their new normal of erectile function and optimizing their recovery from a quality of life standpoint. And one thing that I won't be able to go into too much detail during this talk today, but good to know about, many patients have seen now these commercials, the bent carrot commercials, Peyronie's disease or penile curvature. One really interesting thing that we found is that patients who engage in these types of penile rehabilitation protocols were less likely to develop scar tissue in the inner lining of the penis so that when they did get erectile function, they weren't developing new curvatures or penile shrinkage, length loss, etc. So these are two different publications directly out of our teams here at UCLA where we published on using daily tadalafil before, during, and after treatments for cancer, as well as using a vacuum pump or a vacuum erection device, really like physical therapy to mechanically stretch the tissues to maintain as much as elasticity and size and normal function as possible. And as you can see there, the main thing we saw was improved time to recovery, kind of getting back to a new state of what is the new normal after cancer care, and reduction of side effects, and side effects in this case being a lot of patients notice penile length loss after, for example, prostate cancer surgery. The vacuum was able to mitigate that along with the daily tadalafil use, as well as prevention of that new scar tissue and penile curvature. And here's another reason why we feel very comfortable, as long as it's safe to offer these medications to patients using the both formulations, but especially the daily doses. And what you see here is that this was a large comparison group looking at hundreds of thousands of men with either erectile dysfunction or lower urinary tract symptoms. That's what LUTS refers to, versus a group of 1 million men with lower urinary tract symptoms, but that they weren't being prescribed these types of medications for ED. And they compared them, they were able to match them up by medical problems. So the groups had a pretty similar breakdown of diabetes, kidney disease, obesity, heart disease, high blood pressure. So they were pretty similarly matched groups, and the findings were quite fascinating. So in the directly from the report, the kind of statistical way, the folks using daily Cialis had a risk reduction of 34% for overall mortality during the years that the studies took place. Heart attack was reduced by a little over a quarter, 27%. Stroke was also reduced by over a third, 34%, and a reduction in dementia in the cohorts. And interestingly, the daily users or more frequent users, daily or every other day, seem to have a association of a better benefit compared to the folks who only use these agents when they wanted to be sexually active versus those who didn't use them at all in the group. And this is just one of numerous studies in the world of cardiology and internal medicine, not even urologic papers that seem to show these potential health benefits and associations. So just another reason that we feel that not only treating quality of life, but potentially optimizing health in other ways as well. But what happens when pills aren't enough? These therapies aren't sufficient. And that's usually when folks make it into my clinic, our practices here in the men's clinic. One of the things that you already heard me mention is the vacuum erection device with the constriction band. Well, the efficacy rate can be quite high, and apologies for the graphic picture, but it's the best way to kind of see exactly how it functions. The device is put on, a vacuum is generated, created, and that fills the penis mechanically with blood flow, and then the constriction band at the base helps maintain it to allow for penetrative sexual activity. So you can see high efficacy rate, satisfaction rate significantly lower, as low as 30% to 70%. And most of it tends to be around this component of just the prep, getting the device, it just ends up being a lot of work for patients. And the sensation can be a little bit different compared to having kind of your own initiated erection. But it definitely has a very important role in these patients who had previous either pelvic surgery or radiation as rehab, those papers that I demonstrated for you guys. The other option, which has significantly fallen out of favor, but I think it's still important for folks to know what's out there, there's intraurethral suppositories. Those actually, the manufacturer stopped making them a few years ago. But there are compound gels from other pharmacies that we can still obtain for folks. The efficacy rate is very low. They're extremely expensive, kind of on a per use basis. So I frankly rarely am prescribing these. Every now and then someone comes in, saw it online, they want to try it. No problem, very safe to use. But those same patients very rarely refill them. It's usually not a long-term solution. Better option pharmacologically for many folks, particularly cancer survivors, are these intracavernosal injections, or many times you'll see the acronym ICI, intracavernosal injection. These can have up to 70 to 90% efficacy rate even when pills have failed. Challenges is that here, most of the time, you do need to at least be seeing a urologist, if not a sexual medicine urologist, because they have very limited insurance coverage. They can be hard to obtain except from verified, dedicated compound pharmacies. And there's some teaching and some education involved where it would be beneficial to kind of get counseled and coached on how to use these. And lastly, as we progress through, there are folks who are not going to respond to pills, either respond initially and fail over time, or they're just frankly not comfortable with the idea of using an injectable medication every single time prior to intimacy. And this is where we talk to patients about the penile implant or the penile prosthesis. And this is certainly the gold standard for severe erectile dysfunction. And there's some clinical cases in which it really may be the only option that's best suited for patients. But across all comers, you can see quite high satisfaction rates for patients and partners. That has been quite well studied. In general, it's considered a low risk surgery, certainly lower risk than a lot of the cancer surgeries that patients have often had by the time I see them. About 45 minutes to an hour of actual surgical time, a little bit longer under anesthesia. It can be an outpatient versus an overnight stay in order to be able to leave the next day without any drains, without any tubes. And the complication rate is relatively low, 1 to 2% infection now that they're covered in antibiotics. That rate is much lower, thankfully, compared to 15, 20 years ago. They are a mechanical device. You see, there's a balloon that holds fluid, a pump that pumps the fluid from the balloon into the cylinders, which is what helps generate the erection. Anywhere along that pathway, you can get a kink or a break or a separation of the tubing. So there is a component of device or mechanical failure. The average lifespan of these tends to be anywhere between 10 to 15 years, depending on most studies. Damage to nearby structures, thankfully, again, is quite low. The P channel, the bladder, the urethra, blood vessels, all those things are things that we look out for during surgery. And hematoma, or a collection of blood under the surface, under the incision, in the modern series also is on the lower side, 1 to 3%. Thankfully, it tends to have minimal change in sensation, orgasm or ejaculation compared to your normal at the time of surgery. But importantly, it doesn't, take you back in time to make someone a teenager or 20 again. So most men over time, and we'll talk about this in another slide in a second, will have some changes in ejaculation and orgasm and sensation just as part of the natural male aging process. But these things can be accelerated with cancer therapies. The three-piece device is the most common, but there are some folks who, during our consultation, we may identify that they're actually better candidates for the malleable implant. You can see that here. Apologies. This can be patients that have a higher either anesthesia or surgical risk. It's a simpler device. There's no tubing, there's no pump, there's no balloon. So you can imagine that a smaller incision and less surgery results in less operative time, less anesthesia time, lower complication risk. Can be useful in some complex cases, revisions, or patients who have neuropathy problems with their hands, with their grip strength from chemotherapy, for instance, who may not be able to adequately pump up the device if we're using the three-piece. So pros are very clear, reduce risk profile, one incision, one component, no tubing, no pump, no reservoir, so less likely to fail. But the con is that you always have a little bit of rigidity in the part of the penis that exits out of the body. So it does require a little bit of kind of maneuvering or tucking in clothing to kind of be more discreet with this type of device. And thankfully, across just Medicare, these are always covered for our patients. Most commercial insurances and most Medicare Advantage programs will also fall into the category. Right now, we're in a unique window. We're in 2025. Medi-Cal actually started covering penile prostheses for these quality of life functional surgeries. I'll be honest, I'm a little worried that with some of the federal changes to Medicaid and cuts in funding, that this may be a benefit that either gets significantly reduced or even disappears in the next 1 to 2 years. So that is something that I'm keeping an eye on and I'm a little bit worried about. There are numerous studies that show for patients reduce financial toxicity, meaning less out-of-pocket costs for patients, because over time, having to use either pills or injections prior to sexual activity or daily pills or a combination does start to add up, particularly when the insurance doesn't cover these treatments. And in many patient-reported surveys, most men do wish that they would have pursued the penile implant 5 to 6 years earlier. Reason being, they say, oh man, I was younger then, I was more active, I was moving around more. I probably would have gotten a longer span of time where I would have enjoyed the ability to have penetrative sex even more than I currently am. In terms of ejaculatory or orgasmic dysfunction, A little bit of a sad slide, but I'm just like to be very direct and honest with folks. These are probably the two domains or two areas of sexual medicine that are most frustrating to see patients dealing with because they're so limited in what we can offer. There are no FDA approved therapies in this space. There's a few off-label things that we'll try. But if ejaculation is lost or diminished after a cancer treatment, often it is permanent. And there's not much that we can do to kind of turn that back on. For the orgasm side, if a patient has low testosterone and they're a safe candidate for having testosterone therapy, that is something we'll try to raise or boost or return to normal levels. And in some cases, we will see a little bit of improved sensation or orgasm ability, but it is not a guarantee. Sometimes, again, it reflects internal changes in the nerves and the nerve function. And so we're not able to undo the damage that time or therapy has had. And for many men, it can take time to adjust to a new normal. There's a period of, frankly, loss and grief that they go through as they kind of adjust to their new body. And now let me shift gears a little bit to fertility. The historic or traditional definition of infertility prior to 2023 was heterosexual couple having unprotected sex for 12 months, 6 months if the female partner is over age 35, because that can impact the chances of fertility. What we saw in the world of medicine is that while this was a very straightforward definition, we saw unintentional consequences. Many insurance companies were actually using this definition to put a very rigid rule of, well, we are not going to cover anything in terms of evaluation or treatment until you've met that guideline definition of infertility. And so, where we certainly saw it impact a lot of patients were cancer survivors, folks whose history, whose background, whose either surgery, radiation, or chemo would have impacted their ability to start or expand the family. And so, thankfully, in recent years, the definition has been purposefully expanded to include this inability to achieve a pregnancy based on the patient's medical, sexual, or reproductive history. So, a much more all-encompassing definition takes into account the medical background, takes into account the LGBTQ plus community, and where some folks may require either donor eggs or sperm or embryos to expand their family, either individually or with a partner. It's also important to put that in context of what goes on in the world of California. So, some real world challenges, like many specialty consults, fertility consults on the male side and the female side, can easily take 2 to 4 months to get in and start having a discussion. Really important for all folks here, patients, family members alike, to be aware that, particularly for commercial insurances, California passed a law in 2019 that should help cover sperm or egg freezing if a patient is going to undergo a treatment that is known to affect fertility. Or the fancy term they'll look for in the insurance side is iatrogenic infertility, meaning infertility caused by something done medically. So just be very aware of that. And sometimes it takes a lot of phone calls and pushing on the insurance side, but something that you should certainly advocate for prior to something like chemo or radiation. And for a while, there was a challenge in the sense that, okay, great, people were able to freeze sperm, for example, what I see. Uh, but then that frozen sperm may is going to require using it for IVF, for instance. And then the IVF side wasn't being covered on the insurance side. So there was still a major gap where the financial aspect was actually the biggest barrier. Well, thankfully, a new law got passed in 2024. It got signed that year, but it kicked into effect this year, 2026, and it's limited. It's not for every single patient, but for folks who work for a large employer, more than 100 employees, a lot of the commercial plans are now requiring a more expansive fertility coverage where it can help us utilize frozen eggs, frozen sperm, etc., to help patients and couples expand their family. For those of you on this call or who are watching this later, this is something, an offering that we have for the community. We have our offices are in Santa Monica. We have an andrology lab here. You do not require a consult, a referral, an MD visit. You can simply call this clinic number and schedule a semen analysis. And sometimes the first step is getting that report, excuse me, that report, that profile to confirm, is there sperm? Yes, no. If yes, are we in normal numbers, or would it be worthwhile to have kind of a deeper dive and a full evaluation? The other option, if geography, transportation, you're very far away, the west side of LA, because of traffic is 2, 3, 4 hours away, it is possible these at-home kits became validated during COVID when everybody was stuck at home. UCLA was actually part of the research team engaged with the confirmatory studies for fellow. And so it is possible to order a semen analysis kit to your home and do at least a preliminary screen from the comfort of your own, home, living room, bathroom, whatever you want to call it. And this is the most important part of the male fertility evaluation. If abnormal, then it is helpful to be able to find either someone in your local community or take the time to get a consultation at a specialty center like ours, where we would typically check hormones, do a physical exam, and kind of put the whole picture together, look for addressable or improvable causes of infertility. And very importantly, I always like to remind folks, unless the finding is very, 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 very few or zero sperm on a semen analysis, even abnormal semen analysis don't mean infertility, that there's not a path there. It may mean longer time to fertility, and frankly, in the prostate and the cancer survivorship world, sometimes finding zero sperm in the ejaculate still doesn't mean that we don't have options. We might need to do a surgical sperm retrieval, look for sperm in pockets in the testicle, and still help couples achieve the family of their dreams. And this is a critical PSA again here. We talked about some of those new laws in the state of California, particularly for commercially insured patients. We don't have cryo facilities at UCLA proper, but it's important to know that your insurance should be able to guide you to say, aha, these facilities are in network for you, for your family member, and you can give them a call and they'll run through the benefits and you'll be able to provide a sample and the facility frees that sample for you. So again, ideally, this is done before any sort of cancer care, particularly chemo and radiation, but just a very important thing to be aware of. These are some of the ones that our patients have most commonly used, both in the West LA area as well as in East LA and Pasadena. And the CSCLA team is going to be able to share a PDF of my slides with folks who send an email or inquire, so we can share this with you folks. Similarly, Fellow actually has a cryopreservation kit. And so for the people who fall in these areas where there's no coverage on the insurance side, actually this is the fastest and most affordable way to be able to freeze sperm. They send the kit to your home, ejaculate, provide a sample, send it back through rush shipping that they provide as part of the kit, and they're able to store that sperm and freeze it for you until the time comes where we need to reevaluate that. And these are just going to start wrapping up soon in a few slides, so we have time for questions. But big picture, there can be both short-term and long-term effects of stuff like chemotherapy. So oftentimes we tell folks that the probability of recovery is highest within the first 2 years after completing chemo. The type of chemo will have an impact as well. In fact, just earlier this morning, before I jumped on this video, there's a patient that's a couple years out from chemotherapy, and he did a semen analysis today in our lab, and it was perfectly normal. So we do see this very rewarding, very positive cases. I often tell folks, let's check at a year. After a year of completing systemic therapies, let's get a new pulse, a new sense of the normal, and then we can always reassess and take it from there. For folks who are having to undergo chemotherapy a little bit more urgently or maybe even in the hospital, ideally, banking is done prior to chemo, but it is possible for some people to be able to bank a couple days, 3, 4, even up to 5 days after starting chemo. And so, rare situations, but important again, just for people to be armed with knowledge that this is possible. And if for folks in the hospital going through this, it's a very important question to bring up to the hemonc, the oncology teams, to ensure that they can help with this component. And radiation and surgery, we talked about it at the beginning, but just important to know that radiation directly to the testicles will certainly impact the sperm production process. But in some cases, if the total body radiation levels get high enough, that can still affect sperm counts. And radiation to the brain, very far away from the testicles, but can affect the hormones. And so in some cases, somebody had a pituitary mass or something else, brain radiation may affect the hormone profile, and we may need to do some hormonal management to try to understand the fertility picture. We talked about checking the semen analysis or sperm 1 year after completing of cancer therapies. Female partner is going to have to undergo an evaluation and may need likely IVF to use the sperm. And lastly, last couple of minutes here. Sorry to focus in on one area of cancer, but for prostate cancer survivors and their family members or their loved ones, still about 10% of patients have persistent leakage of urine after prostate cancer surgery at 9 to 12 months after their surgery. This can also be seen in bladder cancer patients, for example, who have a neobladder or those with other rectal or pelvic cancers. Number of things are done in the early process with the oncology teams, pads, diapers, penile clamps. But if you're getting to 9 months to a year, it's important to know that there are two surgical options that can really be life-changing for patients. One is for milder incontinence, 1 to 2 pads, and this is called the male sling. And it really just puts a little bit of pressure and support. As you can see here, this is kind of a shot looking head on under the urethra to provide a little bit of additional hammock or support to reduce the leakage. And many patients with mild incontinence do quite well. And you can see 94% would recommend that procedure to a friend. And the artificial urinary sphincter is the gold standard, particularly for the more severe incontinence patients who have undergone both surgery and radiation. It is a mechanical device. It does require activating or using the device, but it'll mimic a healthy sphincter and it'll return that control to the patient. And so essentially, when it's time to urinate, a patient reaches down, feels this little button, they press it, and that actually activates or opens the cuff so they can empty their bladder. And after about 90 seconds, that pressure is restored and goes back to normal. And you can see the satisfaction rates here are incredibly high when this is the appropriate treatment strategy. And so lastly, I'll kind of leave this up in the background while we do the Q&A. But I see folks both at UCLA. I do a lot of telehealth as well as at Martin Luther King in Compton. And so this is a passion area of mine. Cancer survivorship is so important for folks to be able to really regain control of their quality of life. And so I'm very thankful for all of you who joined us today to listen in. All right, I'm going to start looking at the Q&A, and thank you all for bearing with me as I kind of clear my throat. I had an aqua ablation and the biopsy showed cancer. Oh yeah, good question. So a patient brought up a question about a aquablation, which is a treatment for enlarged prostate, so not cancer. However, the biopsy ended up surprisingly finding a cancer. Ejaculation was impacted by the surgery. Will it be reversed through time? It is certainly possible, and so it's important to give it a little bit of time to kind of get a sense of the new normal. But in many cases, if at 6 months to 9 months it hasn't come back on its own, it is likely that that's a permanent effect of the surgery. Most of the BPH or enlarged prostate surgeries will have that as a potential side effect. And unfortunately, when it does occur, even when it's a lower risk of the surgery, when it does occur, it tends to be more permanent. And then we have another comment here. Surgery removal about 7 years ago. Radiation 1 year ago. Must wear a pad for leakage, and using a pad to manage. So yeah, you've gone through. It's already been some time, and certainly some time from that period of radiation. So I think it'd be worthwhile to come in and again, I have no ego in this. I just love for patients to be aware of options. But whether it's UCLA, if we're in network or close to you in the community, or our colleagues over at USC, Cedars, etc. I think the most important thing is that many folks often don't feel either comfortable or empowered to bring up these things that affect quality of life. The sense it's kind of like, we treated the cancer, we did it, we won. But especially once you get further out from your treatments and therapies, I want you to feel very comfortable, either yourselves or family members, being advocate of how do we address these other components of, again, not just quantity of life, but quality of life. And that can include sexual function, that can include urinary control for our prostate cancer patients, or even enlarge prostate surgery, as you heard before. So these are great questions. Oh yeah, there's a question here, a little bit off topic, but what I'm going to answer it because why not? We're here. So there's a gentleman who had a prostate biopsy and has some blood in the ejaculate several months out. It has continued. That can be a tricky one. Most of the time, it will resolve within 6 weeks to 3 months for most people when it's post-procedural after a biopsy, which is a very important step in diagnosing prostate cancer for all of those who are listening. Thankfully, it tends to be benign, very unlikely to harm you or harm your health, but it is incredibly annoying and frustrating for both patients and partners alike. If it's still persisting and you haven't gotten a chance to kind of have a sit down with your oncologist or whoever did the biopsy, it's always worth checking in. Sometimes off-label things like finasteride, the medication that helps shrink the prostate a little bit, will help that bleeding get under control a little bit. And Kathy, I think you had some questions as well from folks who registered. They may or may not be here today.
We do have a few questions that came in at registration, and if you are attending today and you have additional questions, feel free to continue to enter those into the Q&A. But there was a really important question. Initiating conversations about sex and taboo subjects. If doctors find this topic uncomfortable, how can patients bring this up to their physician?
Oh man, that is probably the most important question to be brought up at something like this because it's so true. And some people, there's actually numerous studies that show a deficit in sexual health training all the way back through medical school, not even including residency fellowship, but that this really becomes something that a small number of subspecialists become really engaged in and involved in. And for the rest of the medical community, if it falls outside of their area of expertise, just like patients feel uncomfortable, doctors may feel uncomfortable. I do think here, particularly if you have a good rapport with whether it's your primary care doctor, your oncologist, if you found that person where you feel comfortable sharing with them, even if they're not going to be the ones to directly manage the problem, I would really strongly encourage all of you on this call or listening to this video later to do a little bit of self-advocacy and say, hey doc, I hear everything you're saying and how these treatments are important for me. But for myself, for my partner, for both of us, intimacy is very important. Can you just go into a little bit more detail into the potential side effects or things that I should be able to expect? That aquablation question that came up first is a perfect example that sometimes the conversations are so focused on treatment, what are the success rates, what are the recovery? Sometimes the potential side effects and the length of the potential side effects can kind of get buried in the nuance. And so I do think it's very important to at least bring up the question because even if they don't feel comfortable answering it or managing it or having the expertise to say, ha, this is step one, two, three, it should at least highlight to them that this is an important part of your life and your goals. And that's exactly when they may say, "Oh, you know what? Let me get you plugged in with a sexual medicine specialist. Let me refer you to see somebody, let's try this first step, for example, Viagra Cialis, while you get plugged in with a urologist to kind of discuss this in a little bit more detail." And so I do find that if you can take those extra, 1 minute at the end of a visit, if it hasn't come up organically, to highlight it, even if that person is not going to be the quarterback or the one who manages it long term, at least they will say, okay, light bulb, this matters. Let me make sure that they have a conversation with somebody who's more adept and whose specialty is focused around this area.
Great, thank you. And I think another question just came into the Q&A if you want to take
Mhm.
a look at that.
Yep. Let me take a look. One group of men with prostate cancer have better, statistically, which group of men with prostate cancer have better erection outcomes? Men who receive radiation or radical prostatectomy? That's a really, really, really good question and a really tough one. Nobody has been able to design the perfect study to say this half of guys are going to only have surgery. This half of guys is only going to have radiation or radiation plus the hormone therapy. Divide them equally and randomize them and look at their outcomes in the long run. As opposed to urine control after surgery, which does depend a lot on the surgical technique. Erectile function is incredibly complex. It requires blood vessels, it requires the nerves, it requires hormones, testosterone. And so it is just so widely variable. Depends on the patient age. Did they have ED already before surgery or radiation? So it's hard to give an exact number as to which one is better. I think what matters is the timeline. So for a person who's younger, for instance, they may go the route of the prostatectomy, the surgery, because they know that while they'll have an impact and a damage that's more immediate in terms of the nerve and the erectile function, they'll have more time to recover and more time to enjoy the recovery of that sexual function over time. Whereas somebody who's getting radiation may not see any immediate impact. But over time, 1, 3, 5 years later, they might start to notice that decline. And so the broader the whole clinical picture becomes really important. I always tell folks, learning from my cancer colleagues, surgery or radiation for the prostate cancer side, in terms of success of treating the cancer, are exactly the same in most studies over and over and over again. What really ends up helping patients make a decision is in the short, medium, and long term, which side effects am I more okay managing? And when that comes into play and that becomes a part of the conversation, is how most patients are able to make that decision of surgery versus radiation. Let me see here. Looks like another question has come
Another
through.
question came in. Yes.
If you are on GLP-1 injections to lose weight, should you stop them after prostate cancer diagnosis? Great question. Should not directly impact anything, can continue them. But again, for all of us here on this video, really, 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 really important if you're going to have anything with anesthesia or surgery, so any sort of surgical or procedural intervention that requires anesthesia, those classes of medications do often have to be stopped a week ahead of time to avoid anesthetic complications. So from the cancer standpoint, very safe, no side effects that we're seeing or associations where you would have to automatically stop it. But if having any sort of intervention under anesthesia, whether it's a biopsy, a surgery, etc., really important for both your surgeon to know and the anesthesiologist to know because you usually have to stop them a week ahead of time.
Great. Thank you. Another question from registration. The best ongoing recommendations for post robot assisted laparoscopic prostatectomy recovery.
Yep, yep, yep. Very common question. These webinars tend to focus in on that area just because A, prostate cancer is incredibly common. So from a pure number standpoint, a lot of our survivorship, we just see more prostate cancer patients. That'll really refer back to that slide I showed you folks with those two different publications on a daily Cialis regimen, often starting at 5, but many people will be able to go up over time if they're tolerating no side effects, and a vacuum pump or a vacuum erection device. That's a wonderful place to start. If still running or dealing with issues or problems, that's a great time to see a sexual medicine specialist to see what next steps can be taken.
Great. And then one final question. Someone is wanting to know the effectiveness and availability of radiofrequency versus surgery for prostate cancer.
Radio frequency, interesting. That may be referring a little bit more to kind of newer or focal therapies in the world of prostate cancer care. That's a tough one, and I wouldn't know the exact numbers. The surgery and radiation, external beam or brachytherapy radiation have been around longer, and there we do know that the long-term outcomes are quite good in terms of treating the cancer. But I think that's a better question for an oncologist, whether a surgical oncologist or a radiation oncologist, to dive in a little bit deeper into the details.
Great. Well, we have reached the end of our time together today. And Dr. Andino, thank you so much for sharing your expertise with us and spending this time with us, even though you had a little bit of a cold.
My
We
pleasure.
appreciate you powering through that. And we have a final slide that we're going to share. And I also want to thank our attendees for just for your engaging questions today and for participating with us during this hour. If you want to learn more about Cancer Support Community Los Angeles, you can visit our website at cancersupportla.org. If you have any questions for us, you can email info@cancersupportla.org, particularly if you had a question today that didn't get answered. Feel free to email us. And as Dr. Andino mentioned, he's going to make his slides available. And if you would like a copy of those slides, you can email us there as well. And then if you are interested in support, you have prostate cancer, there's information about our prostate cancer support group here, which meets the first Monday of every month from 6 to 8 p.m. And you can also email us at the same email address if you have interest in that group. And we thank you so much, everyone, for joining us today. Have a great rest of your day, and we hope to see you at a future webinar. Take care.